Well, welcome one and all to session 2 of our seminar series. And when I say welcome, I mean welcome to a wide range of people. So welcome to the University of Edinburgh. Welcome to the Institute of Sport, Physical Education and Health Sciences. Welcome to the School of Education. And welcome to our colleagues who are joining us from Canada and the University of Toronto, since these are part of our Edinburgh-Toronto seminar series. Our speaker today probably needs no introduction to many of you. He's been a well-known figure on the Scottish and British scene for a long, long time, an experienced person on British and Scottish sport. He's a long-serving rugby team doctor, Dr. James Robson. He's received recognition from a number of places, and his services, are an impressive list of people, clubs, countries, and of course, including the British Lions. And he's one of the few known surgeons to be recognised by the Royal College of Surgeons in Edinburgh. We're delighted to have him here for about an hour. James has expressed that he would like it to be a discursive session, so it's a very topical issue in terms of the topic that we're covering today, and he's looking to both contribute but also learn from what this audience has to say on the subject. I think we're going to have about 45 minutes, or as much time as you would like, James. And the topic, in terms of today's contribution, is the role of the team doctor and head injury in sport. So over to you, Dr. Robson.
Thank you very much.
Thank you for being here.
Not at all, thank you. I think by long-serving he meant old and ancient.
Not at all.
Yeah,
not
no.
at all.
I think experience comes with age, but not necessarily wisdom. So apologies, what I'm going to tell you is not necessarily what other people would tell you, but I'm just going to tell you some of the things from my experience. I started life as a physiotherapist and then moved on to do medicine, and I've combined the two. And I've been very, very fortunate to end up in sport. I played rugby as a youngster. I left it for a little while. I came back to it, and then found that I was starting to pick up one or two injuries that might impact on the way that I work. So I actually modified what I did. I wanted to stay in rugby, and I started looking after other players, and I withdrew as a player a long time ago. Medicine has been my life. I get most of my kicks out of trying to help people. Some people don't necessarily want to be helped, and some people you can't help. But I really enjoy my job for most of the time, never more so than when I'm at pitch side. We've just had the autumn tests, which were quite combative in many respects. I think reasonably successful from a Scotland perspective. When I've done talks in the past, I've said that one of my handicaps is actually working for Scotland. I have to say that I think we've turned a corner in the recent matches, so I'm delighted to stand up and be proud of that fact. The main topic today is head injury. I'm going to discuss a little bit about what I do as a team doctor, but I was asked to speak about head injury. It has become immensely topical in recent days and weeks, with the very sad and tragic events in Australia, losing one of the world's best cricketers. Subsequently, another accident where we lost a cricket umpire from being struck by a ball, and then a very serious injury just at the weekend there down in Blackpool to a hockey player. So whilst I talk about head injury in sport, and I'm going to principally use examples from rugby because that's where I work, sadly, events very tragically have manifested themselves in other sports. One of the most high-profile cases of recent times is Michael Schumacher. I'm going to be speaking to some of the guys about driving later on today. Of course, sadly, he's going about his recreational enjoyment, skiing, and has an accident and sadly sustains a very nasty injury there. Head injury can happen in any walk of life. Is anybody aware of, in Scotland, what is the most common cause of head injury? I'll give you a clue, it occurs at the weekends. And it's usually people, it's usually either driving, or more likely, it's actually people falling downstairs having had too much to drink, resulting in head injury. The most prevalent head injury that we're going to speak about is concussion. And previously that was seen as a badge of honor, it was seen as a joke, but it's no laughing matter. The bottom line is that we get one brain, we have one brain, and it's beholden on us to protect it as best as possible. So why do we need medics? Well, I've already given you a clue. Why do we need medics in sport? Why do we need medics in rugby? Well, in rugby in particular, it is almost a collision sport. It is certainly a physical contact sport, and injury will happen because of accident, usually because somebody gets their head in the wrong place, gets their arm in the wrong place, or even somebody commits an act of foul play. It's often rule transgression that can result in injury. As an example, Brian O'Driscoll, British Lion, fantastic player, dislocates his shoulder. He can't put his shoulder back in himself. He needs the help of the medics. Sometimes it's just because it's a team sport and somebody has to carry the bags. I think that's part and parcel of the ethos of being a team doctor. It is a team sport. Even it's a team sport if you're involved in an individual. I've worked with golfers, for instance. I've worked with tennis players. You then become part of a much smaller, more intimate team. But in my team, it can be one or two people. It can be 20-odd people. When I first started, as Grant very kindly said many years ago, my first British and Irish Lions tour was to New Zealand. The management consisted of 5 people: a manager, a head coach and an assistant coach, a doctor, myself, and a physiotherapist. 5 people, 36 players, 8 weeks touring to New Zealand. Contrast that with the first truly professional tour, and all of a sudden you've got 6 in the medical staff, 2 doctors, 3 physiotherapists and a masseur. You've got 28 management, but you've still got 36 players. So you've got a manager, a manager's assistant, you've got a head coach, an assistant coach, you've got a scrum coach, you've got a defence coach, you've got a kicking coach, an attack coach. People have almost invented subspecialties in coaching, and that may be very relevant in your walk of life. It's a bit like medicine. You now, if you've got a particular type of shoulder injury, go to one surgeon rather than another. You don't go to A&E and expect to see the same doctor dealing with everything that you might present with. You go to your general practitioner who says, I think this might be what you have. However, I know somebody that will know a little bit more about that. You cascade down, and it would appear that that's what's happened in team management. Even more so in team medical management. We now have sports physicians, general practitioners, surgeons, we have nutrition, we have the physiotherapists, we have our allied professions in strength and conditioning. We work closely as a wider team. I mentioned head injury. Head injury can come in a number of guises, and I'm going to show you 1 or 2 examples and then ask you to do a little bit of work. Well, this is Hugo Southwell against Wales. He's just sustained a head injury. What kind of a head injury? You see it better from another angle. Up he goes, pulls out of the tackle. Face versus a studded boot results in quite a nasty laceration.
Thank you.
You'll agree, quite a spectacular looking injury. Contrast it with this scenario. Rory Lamont has just sustained a head injury. Very difficult to diagnose immediately. One of the problems and one of the beauties, perversely, about rugby is that play will continue even when injury has occurred until it becomes obvious that it's a serious situation. You can see the wider medical team in action there. Not only is the team doctor responding to the injury, you've got the assistant pitside doctor, you've got the paramedics, you've got a wide-ranging team to look after that player. Some of the injuries are caused by foul play, some of them are caused by just the nature of the game, some of them are caused by individuals because they play in a style that lends themselves to danger. That is part and parcel of being a sports person. You choose to play your sport in a particular individual way. As you can see, Rory has a style that lent himself to injury. That was him sustaining his second head injury in another guy's in the World Cup in France. So, how do we prevent injury? One of the ways that we prevent is by coaching good technique. One of the ways that we prevent injury is by looking at the rules and seeing whether we need to modify the rules. Prior to this talk, what would be your perception? What causes more, what situation in rugby causes more injury than any other? Anybody? Scrum? Tackle? Any advances? Probably the two best answers, actually. It used to be the scrum, and now it's the tackle. Why has that changed? Because the powers that be have looked at injury patterns and identified that front row play was quite a dangerous area. Collapsed scrums, the engagement, the collisions that were involved, the individuals that were there, that has evolved such that that injury risk has been reduced. But the most common area for resulting in an injury now is either tackling or being tackled. If you're tackling and you get into the wrong position, you might injure your neck, you might injure your shoulder. If you're tackled and you fall awkwardly, for example, you might land on the point of your shoulder and dislocate it. So it's very interesting, and of course, modern technology, in particular video technology, has allowed us to look at injury and therefore decide what has actually happened in any particular situation to a much greater degree. This is an interesting scenario. I'll let you see the video and then we'll just talk through it. Injury's just occurred. Play continues as we've described. The aging doctor, as Grant has pointed out, has just attended to the casualty. Play continues. The medical team are doing their work, and the player recovers in a Lazarus moment. Let's see that in slow motion. Bang, injury occurs, dislodges his mouth. But 20 seconds later, he's back up and ready to go. What actually happened? Run on. Al, you okay? Al, you okay? That's actually him, not me. I'm quite reasonably fit. Al, are you okay? Al, it's okay, you've got laryngeal spasm. I actually talk to my players as if they are medics because most of them are au fait with the medical terms because they're so used to injury and illness and having medical people. Got laryngeal spasm. Just take your time, your breath will come back. Al, it's okay, we've still got the ball. Al, play's moving away. Keep them informed, keep them reassured. Al, how are you? Yeah, it's okay, just take your time, take your time. Al, they've got the ball. Al, their back's kicking it. Al, effing get up. That was actually what swayed it. It's perhaps not the most kosher of bedside manners, but sometimes you have to use a vernacular that actually suits the situation. So I work in an environment principally with men who swear a lot at times, and it rubs off. I try when I'm in my general practice setting or in here to modify my language. Occasionally, it doesn't work. So when I came back off an 8-week tour to New Zealand, my first patient in my GP surgery the following day. I made the mistake of going straight into work the following day. These were in the amateur days, so I didn't get paid if I wasn't there. Mrs. Smith comes in, she sits down. I greet her cheerfully but slightly jet-lagged. "What can I do for you, Mrs. Smith?" "I just came in to see how the tour was." "For F's sake, Mrs. Smith." You forget where you are, so you've got to be very careful. But language is important. Telling players what the potential injury is, how they might recover, giving them reassurance, even when you're actually quite scared, is very, very important. I mentioned video analysis, and you've been subject to a number of scenarios here. This is quite a nice one, and this is one for you guys to have a look at. You tell me what the injury is here. Pardon if anybody has seen it, and please keep quiet, because I've used this video for teaching on a couple of occasions in the past. So the injury is occurring, and it's occurring in front of you, as it is occurring in front of everybody that's there. We've highlighted the guy that's been injured. Apologies, this is a fairly historical piece of footage. And I hasten to add, even the South African was concerned, which gives you a measure of the seriousness of the injury. Not that they're not concerned, just at the time it seemed an obvious thing. The other interesting thing is, of course, keep an eye on the time. So the injury has just started to occur, and time is ticking, as they say. Anybody hazard a guess at that injury? This is many years ago. Yeah, he's collapsed, but a few seconds later, he's now saying, you know, what happened? And he's fine, and he answers all his questions, and he's perfectly steady. And in those days, we didn't have the option to take him off, and we allowed him to play on, and he scored the winning try in what was the first victory of Scotland against South Africa for many years. So perhaps the clinical decision was correct. In hindsight, it might not have been, because we now err very much on the side of caution. But he lost consciousness because the opposition player came in and put him into an arm lock, occluding his carotid arteries, including his ability to get oxygen to the brain through his trachea, and subsequently he loses consciousness. Why is that a problem? Well, it's a problem because if you hold that long enough, then something untoward will happen. So we sent that piece of footage when we'd analysed it, and I'm talking many years ago, as you can see from the footage, to the South Africans, and they subsequently brought the guy in and said, you know, what's going on here? And you learn from that. So we learn from the fact that a headlock might result in serious injury. So using video technique is very, very useful. I shouldn't have put that slide up for you, because I was going to ask you the question, concussion. What do you know about concussion? What is your perception? What is a concussion? Anybody want to? It is to do with the brain, and it can result in swelling, so those are very good points. Anything else? Anybody want to hazard a guess? Concussion is a disturbance in the function of the brain, usually, well, most often temporary, from trauma. We'll let you see the slide. Why is it a hot topic? It's a hot topic because, as I said to you, get one brain, and we have to be ultra protective. It's a topic because in America, head injury has resulted in multi-million-dollar litigation. It is a topic because it is a highly emotive subject, because if we want people to play rugby or to play sport, then we have to minimize risk. And one of the risks that is posed to parents every day is, would I let my son or daughter do a particular activity which might result in injury? We also are beholden on looking at concussion very carefully, because we're not sure, I say we globally, we're not sure what the long-term potential consequences are. So this has resulted in an enormous discussion about one subject. Sometimes that takes the eye off the ball, and you lose a perspective you think that everybody's concussed and that concussion is the only injury or incident that might occur in a particular game. And that is not true. We have to remember to look at other injuries as we've already discussed. But the symptoms are many. The most common are headache and dizziness and nausea. The signs, the obvious one is somebody's lost consciousness. They've had a minor traumatic brain injury. They've had a disturbance to the brain function which has rendered them unconscious. You might see that they have a seizure, a fit, or they might get up and they might almost appear drunk. Anybody aware of the first sort of description of sport-related concussion, sport-related brain injury was? What's the name given to that? What sport did it occur in? Punch drunk, that's right. So-called punch drunk syndrome or dementia pugilistica. Pugilists were boxers back in the day, even before my time, a long time ago. But that was first described in the 1920s. So head injury has been a subject for a long time, but only recently has it become large in the public domain. One hopes to learn by one's mistakes. I certainly feel as though I made a big mistake in this particular piece of video, and this was almost trial by videotape. How many people would miss that concussion? Well, I did. I was 6 seconds away. I was, arguably about 30 meters. And at the angle that I saw that, I actually started to run onto the field thinking that I was going to treat one of the Wales players, Martin Williams, because from my angle, it looked as though he had sustained the injury. But as you can see, Simon Webster from Scotland was the recipient. Worldwide, an audience of many millions made that diagnosis because they saw that incident in glorious high-definition slow motion on several occasions. At pitch side, you see it real time, not always from the best angle, and in the blink of an eye. In those days, we came on, "Are you okay, Simon?" He was talking to me on arrival. "I'm just winded, I'll be up in a minute." That's fine. Gets up, answers all the questions, has no problems with his balance, and promptly plays, arguably, some of the best rugby of his test match career. So for the next 12 minutes, he plays superbly well. At 13 to 15 minutes, he's being attended by Duncan Hodge, a great player in his day, but not a medic. Why was that? Well, that's because sometimes lightning strikes twice. So while Simon is still okay, this occurs. Jeff Cross, in his first capped international, 20 minutes in, even the referee makes a diagnosis, he's out. He actually gets yellow carded, but he doesn't get shown the yellow card because he's unconscious, which I thought was nice of the referee. But that's an obvious diagnosis. Watch it from another angle as the worldwide audience saw it. That's very easy. If I tell you that from a head injury point of view, he could have played a week after that, but tell you that he didn't play for 8 weeks, why might that be? This is something important to learn. He didn't play because he sustained medial collateral ligament damage to both knees, because having been rendered unconscious and therefore unable to save himself, he falls in such an awkward way that he actually sustains 2 other injuries. One of the other learning points from that particular piece of video was the reaction of the players around him. The Wales players go to remonstrate with him. They grab his shirt, lift him up, realize he's floppy, get a fright, and drop him again. If you suspect a head injury, you should always suspect a neck injury as well. Most of the time, fortunately, that doesn't occur. However, you must be aware that somebody that loses consciousness has undergone a tremendous force and that there may be additional damage. In Jeff's case, fortunately, or sadly, depending on which way you look at it, his damage was to his knees. He's since recovered. I don't know if you saw him in the autumn test, he's sprouting the most disgusting beard at the moment, but other than that, he's a really nice guy. So he doesn't appear to have suffered lasting effect. I say he doesn't appear because we go back to what I said earlier. There is worldwide research being done, and it's incumbent on us all in sport, particularly in contact sport, to do research to see what the long-term effects of certain things are, and research into concussion is myriad. So you've now learned that it can be obvious to lots of people, but not necessarily the person dealing with the casualty. You've also learned that concussion might be a transient problem which then manifests itself obviously 15 minutes later, and it can occur 2 or 3 days later, so you have to be well aware of what somebody might have been done, how they present, what their history is, take a very careful look. Or it might be so obvious that even the referee makes the diagnosis, he's out. So that shows you the spectrum. I'm going to show you a slightly different but related scenario again. Make it easy because, of course, I put the titles on the top. So this is another concussion. And in fact, this is two more concussions. Bang. So double injury there. We've now got a Scotland player and an England player, both with loss of consciousness, and a doctor who's actively interfering with play. We are told as medics that we mustn't interfere with play. We must enter the field of play when it is safe to do so. This is the only time I believe that I've acted against the laws of the game. But one of the things that we're allowed to do in rugby, which is, I think, unique in sport as medics, is roam the touchline and enter the field of play if we feel an injury, a significant injury has occurred. And in this particular case, I decided to actually bring play to a halt because the 2 injured players were in danger of being trampled by people who were continuing to play and didn't know about it. Unfortunately, the referee and the linesman actually acknowledged that and stopped play before I got injured. I said there were two injuries. Ugo Monye in the white team, the England team, lovely guy. Sadly had a neck injury. Kelly Brown made the diagnosis much more easy for me to make. I felt that he'd lost consciousness, but he clinched the diagnosis because when he opened his eyes and he looked up at me, he uttered the immortal words, "I'm okay, Lisa." So, enough said. He hasn't been allowed to live that down. Having sustained a head injury, what do we do? In the acute situation, it's down to medical management. Do they need to go to hospital? There are certain criteria that demand that we scan people. And I'm talking head injury, not just in rugby, but head injury per se. If we decide that they are concussed, then when can they play? I think rugby deserves some credit here because they've taken that question and looked at it very carefully and come up with a formulation for return to play that has evolved over a number of years. You might be aware of the document, the Zurich consensus document on concussion. This is a gathering of the best brains in the world occasionally to discuss all things concussive related. Within that, individual sports can look at that kind of documentation and that kind of advice and adapt it to their own sports. So in order for us to return people to play, we do a stepwise progression. The first essential thing is to make sure that the player rests. And by rest, I mean total rest. What we tell them is no video work, no video gaming, no watching television, no trying to read the press the following day. Just chill out, take it easy, let your brain rest. No physical activity other than the normal activities of daily living, just walking about. When they become symptom-free, and they must become symptom-free for 24 hours, we start on a graduated return to play. The first challenge is just to get the blood flowing a little towards the brain to see what effect that might have. So we usually put them on a bike for 15 minutes, steady state, not raising the pulse above 100. Some people would say keeping them at 70% of the maximum heart rate in exercise. You set your threshold, you keep an eye on them, you exercise them 15, 20 minutes, and then you give them 24 hours. And you see whether any of the symptoms, headache, fogginess, not feeling right, irritable, difficulty sleeping, more emotional than normal, sensitive to light, as I said, a myriad of symptoms. We ask them a lot of questions. If those are negative, then we say, that's fine, we'll move on to the next stage. The next stage is to shake the brain up a little more. So instead of biking, steady state, we send them off for a run. Off they go, running around, just sugar the brain up a little. 24 hours. If they're symptom-free, light aerobic exercise, get them puffing, get them blowing, but keep it safe. If they're safe at that point, then they can enter the sport-specific exercise, passing the ball, doing running drills, but keeping non-contact. At this point, we introduce cognitive testing. So we test all our players at the start of the season on a platform called Cogstate, which is a computer-based system, but you can do paper-based systems. There are a number of proprietary systems. So having got to this point and maintained symptom-free at a particular level of skill and exercise, we then test the cognitive function. If that comes back as comparable with their base rate, then we expose them to the next step, which is to give them some contact. And then they go 24 hours again. If they stay symptom-free, they're passed to return to sport. If they become symptomatic at any of these stages, they step back one step. That's the current state of play. We're still examining that. Should it be that they step back to the start? I'm not sure, but that continues to evolve. But the graduated return to play protocol is something that I think that we could adapt to most sports. What's the take-home message from me? I go back to the role of the team doctor or the supporting physician or really anybody that works in sport. Training can, in effect, save lives. Practice makes perfect as far as I'm concerned, or at least it can help. We practice to get people off the field of play with the worst of injuries in order that the extrication becomes easy and safe. And one of the things that I go around trying to teach people is what not to do. So in the instance of Simon Webster with the Welsh players, lifting him up when he's clearly unconscious and then dropping him, that's not what you do. So sometimes the message is not what you do, it's what you don't do. There are lots of courses around. We have Scrum Caps, quite a clever acronym, Scottish Rugby Union Medical and Cardiac Pitchside Skills. The RFU, the Rugby Football Union, have a similar course. The Welsh Rugby Union, the Irish Rugby Union. We have evolved worldwide standards of pitchside care in rugby. Again, that's something that might be adapted to other sports. And I've named one or two, but it should be for all sports. It's incumbent on us to make efforts to help anybody that might get injured. Unfortunately, my talk, in order to labour a point, is very much like Crime Watch. You know, I don't want you to have nightmares, so I can't end on doom and gloom. As I say, working with Scotland has recently taken a marked turn for the best. But one of my favourite pieces of skill is this particular try, scored at Croke Park in the Six Nations with a very famous win against Ireland. Johnny Beattie scoring a fantastic try there, I think you'll agree. One of the jobs of the medics is to make sure the players know that time is up, and time is critical here. We've got to get the ball out. So you see the medics shouting, Hugo, Hugo, kick the effing ball out. You'll also see the fact that it's very difficult for the medics to totally remain dispassionate. I do love my sport, I love my job. Sometimes it's the best of worlds, sometimes it's the worst of worlds. From what you've seen, it's a mixed bag. But I hope that's given you a small insight into the work that we do. Thank you very much. Thank you.
about doing the cognitive testing. How much faith do you have in the quality of information you get from that?
It's a difficult one because, of course, it's been brought in slight disrepute recently by players saying that they've in the past falsified their baseline data. I was taken aback by that accusation because I've done the test and it's quite difficult to actually get a very slow reaction time in this particular one and actually then be a valid test. So I think there are degrees of anecdote in that particular scenario. I don't know truly whether it will evolve that these tests have been worthless or not, but at the moment it adds a layer of protection almost, because if you do fail it, we stop them at that point and we return them one step back. But there are paper things, so there's the SCAT3 concussion testing. So basically a paper exercise where you ask 20 questions, you then ask them things like you ask five words. So I'll give you an example. Go elbow, apple, carpet, saddle, bubble. Now, I can give that off pat because I ask it virtually every day in my professional life. Unfortunately, if you get players who have had concussive testing done more often, they will recount it almost automatically as well. So we now have 5 lists of words, and I occasionally mix them up just to fool the players. We ask them digits. We say, I'm going to give you a series of digits, 1, 2, 3. I want you to recount them backwards, 3, 2, 1. You ask them then a few minutes later, what were the words I asked you earlier? So they get a chance for delayed recall. We do some reaction testing. We do finger to nose. We ask them the months of the year backwards. We ask them to walk along a white line, toe to ankle, 3 meters, there and back in a specific amount of time. So we have tests that I think are helping us, and I think we have come on enormously, but I don't think we're there yet. A lot of money is going into technology to help. So we're now seeing people with iPad technology apps that measure a particular sway. So instead of asking them to walk along a white line, we ask them to hold the iPad and close their eyes, and then we measure the sway against the baseline. I've been contacted just in the last few days by a global company who want me to have a look and perhaps trial some of their software in a way. So a lot of money being spent. We said head injury in sport. You know, some of the most high-profile, most highly financed sport is motorsport, in particular F1. And sadly, you know, we've seen injuries that have occurred in there, but they are a sport that has evolved in safety because they've had to do so. So you've now got the head restraints. You've got guys who work out in the gym because they know that neck stability is a very important facet of being able to drive safely. So I think your question is, how much faith do I have in the cognitive testing? I treat it as it is at the moment, but always have that healthy skepticism that there might be something better and hope that we continue to learn from what we've got. Sorry, a long answer to a very short question.
Tony, you were going to come in?
Yeah, thanks, James. You mentioned research as being one of the areas that we're looking at the minute, the sort of long-term effect of concussion and repeated concussions and so on. What are the other sort of priority areas you see as being relevant for research on concussion at the moment?
I think it is this, you know, at what point are you safe to return to sport? How many concussions are too many concussions? And indeed, is there a long-term effect? But in the more short term, for instance, when should you allow somebody to get back behind a wheel if they've sustained a concussion? When they should be allowed to drive? We have a graduated return to play for how they should respond to playing rugby. Let me give a slightly more obtuse example. When we go abroad and we travel X number of hours, we then have the problem of jet lag. Jet lag in itself can result in in coordination, and therefore when we start to train abroad down in Australia, we give the boys several days where they don't actually do contact work because we deem that unsafe. Is there a measure that we could have that says, if you've been concussed, this is what should happen? Another area of research, and some of it's already been done, but I think there's more to be done, and by magnifying it or repeating it, we might actually get more information. But it's, what do people understand by minor traumatic brain injury? What do they understand by concussion? And I'm talking lay people, I'm talking professional people. So if you present to an A&E department, are you going to get the best advice? Do they know the advice? Or somebody comes in, oh yeah, I got a concussion. Yeah, it sounds as though you got concussed in the rugby match. When can I play? Oh, you'll be fine for next week. We in sport, we don't say you're fine for next week. The elite people who have medical attention every day might at the moment return in a week's time, but you can modify that. But research into the educational message, I think, is a very important place. Willie Stewart et al. Across in Glasgow did a very nice piece of research where they went into schools and they asked school teachers and school pupils and parents their understanding of rugby. That was quite illuminating. I was at an emergency medicine conference down south in Exeter a wee while ago, and we asked a number of questions of the audience and asked them what was the most common presentation for concussion, and they actually got it wrong. These are highly skilled professionals, but it's become almost a niche market because it was previously thought that it was a bit of a joke, but now it's actually seen as a potential public health issue. We've gone on leaps and bounds, but there's still a lot to be done. So, pick your area of research and find the finance and get on with it, Tony. Yeah.
Sounds good.
You've used video clips a lot in your talk, which is great. Do you ever find that you've got access to those quickly enough to then use them to aid diagnosis?
That's actually a really good point. One of the recommendations from the IRB that we have the ability at elite level to ask for what's called a head injury assessment. You get 10 minutes to take the player off if you suspect that they might have sustained a concussion. If it's obvious, if they're ataxic, if they're unsteady, if they're vomiting, if they can't answer your questions, you can make the diagnosis there and then you take them off. But sometimes somebody says, I think he's just not quite right. And you can actually now ask for 10 minutes to take them off. You ask some of the questions that we've already discussed. You ask them to do some of the tests, and then you make a decision. But based on that and on your clinical suspicion, you can proceed from there. One of the things that's very valuable is to be able to have a look at video technology. But of course, that's difficult to get that in enough time. But we are trying to make an effort, particularly at international level and professional level, to have access to video material. Because had I had access to the video of Simon, I would have made the diagnosis like that. Because I can assure you, judging from both my email and my phone boxes on the Monday morning following that game, there were a lot of people that made that diagnosis, and there were a lot of people that were seriously upset by my inability to make it. But I think I've learned from my mistakes. That doesn't mean that I will recognize every concussion. It simply means that I have a different perception of the problem than I had several years ago. But video technology can work to a great extent. It's a very powerful tool in education. It's a very powerful tool in research. You can look at things, you can slow it down. I was watching a game at the weekend that I had nothing to do with. I was watching Wales versus South Africa. And I saw John de Villiers get injured, and my daughter was subject to that being replayed on several occasions while I was busy trying to make the diagnosis before it became public knowledge. She has become less squeamish than she ever was. In fact, she actually probably knows more about rugby than I do now. So.
Two things. Scrum caps, are they helpful in protecting head injury? And do you think there's anything in terms of location of impact and blow that we need to be more mindful of and careful about?
The only thing that a scrum cap will do is protect you from getting cauliflower ears or from some abrasions around the head, by and large.
We've done some research on that.
Yeah.
Looking at scrum caps, we did at MIRA, the Motor Industry Research Association, with proper crash test dummies.
Yeah.
And it reduces your chance by about 2% of getting a serious.
Yeah, I mean, in rugby, it probably has no protective effect whatsoever. And the worry with using a scrum cap is that you get a perception. So youngsters using scrum caps to protect themselves have to be told this isn't a license to use your head. And part of the problem that occurred in American football was the fact that the helmets they used gave them a feeling of invincibility. Also, I think the IRB regulations changed, but they did say that there wasn't a minimum for padding. In other words, but there was a maximum. Yeah. So they couldn't be harder than a certain amount. So you couldn't use them as a weapon. So the IRB were more concerned about using your head as a weapon. Yeah, very much so. Yeah. As opposed to the cushioning effect. Despite the fact that occasionally you'll see some people with what look like enormous biceps or a big thigh, and it's clearly padding, the regulation is a very specific at 5 millimeters, and a particular type of deformity. And the same went with the headgear, so it has to conform to a particular standard. But yeah, a mixed message with that. It can be useful for youngsters in protecting their skin and their cosmetic appearance, but it mustn't be allowed to fool them into a fact of being Superman. It doesn't work that way. Superman's perhaps a bad example because, of course, he didn't wear a helmet, but the Flash or the Green Hornet or somebody else. I used to get comics as a youngster. So.
I was interested in what you're saying about practice makes perfect. You spoke about practicing taking players off the field. Could you just expand on that a little bit in terms of that scenario?
Well, the word scenario is entirely correct, or the word moulage given to practice in a clinical situation. What we do is when we're teaching people how to manage injury, we put them into that scenario. So we'll put somebody on the floor and say, right, pretend that they've got a neck injury, pretend they're unconscious, pretend they've got difficulty with their airway, and then examine the ways that you can get somebody safely packaged, in effect, and off the pitch in a timely but very safe manner. So some of it involves spinal injury, using spinal board, using scoop, using a variety. You can use what's called a vacuum mattress. Other times it's using airway adjunct if somebody's sustained an injury to their airway where they're having difficulty breathing. Other times it's wound management, so simply advising people that they should have gloves on for their own protection because blood's one of the best transmitters of infectious diseases, and with global travel, of course, infection can be spread so much more easily. So there are a number of scenarios. So Scrum Caps is a 2-day dedicated pre-hospital pitside course. In effect, we've looked at what people do with the ambulance service, we've looked at what they do with the helicopter service, with mountain rescue, and we've evolved a package that looks specifically, in our case, at how we manage rugby, because rugby occurs on a variety of surfaces now, artificial surface, natural surface. If it's grass, it can be grass as we now know it at Murrayfield, or it can be grass as we used to know it at Murrayfield, which was a worm-laden sort of midden of sand and mud. And so you can get, I've been in games where there's been danger of drowning because there's been so much water on the pitch. One of the most amusing injuries that I've seen was almost antifreeze poisoning, because we played a game in Italy where they'd actually put antifreeze and grass clippings down to try and soften up what was a frost-laden ground. So there are a variety of situations that you can be called to deal with, but more typically it's the ones that we've seen on there. How do you get somebody off the field if they've sustained a head injury, potentially a neck injury, and they're unconscious, for instance?
Someone ask one more question?
You may.
At the lower level, schools rugby and amateur level, what would be one of the best solutions to addressing the problem?
That's a really, really good question, and perhaps the best question of lunchtime, because 96-97% of, in my sport, rugby, is played at amateur or school level. It's not played at professional level, where you've got a cohort of highly trained medical people at pitch side available. So what do we do there? Well, we look at modifying the rules. So at a particular age, you don't have contact. At a particular age, you don't have scrummage. So look at the way that we allow them to engage in the game and evolve over time. We look at what facilities we advise. We look at training of the coaches in particular. So, we have a course, Are You Ready to Play Rugby?, which helps to teach coaches how to coach rugby in a safe manner. You can do it as a player, you can do it as a parent, and you can learn. If you do get injured and there are not medics there, how should you manage that? So we've evolved a course called FAIR, First Aid in Rugby, which we teach to lay people. I'm going to a school on Monday next to teach 12 PE teachers simple ways of recognising injury, illness, and how they might manage it, and in particular the message that I gave earlier on, what not to do. Recognise where there's a potentially serious situation and don't make it any worse while you're waiting for professional help. So that's the ways in which I think we can help to evolve the management in the amateur and the school. And that's a work in progress as well. For instance, in Scottish Rugby, we've held several courses. We're using a model that we've developed with the IRB, First Aid in Rugby, which is available online. I would commend, if you've had any interest in today's course and you want to research it a bit better, there is a superb website called IRB Player Welfare site, and on there's both medical information, there's strength and conditioning, there's nutrition, there's lots of aspects of player welfare, and it's a wealth of information, and it will only cost you the time it takes to register. And you can do the modules on concussion and concussion management. You can do the module on first aid in rugby, and if that gets you going, then you can come along and do one of our one-day courses for the practical aspects of first aid in rugby. Because the more people that we have trained, it's a bit like the old, and this is showing my age, the old campaign, many of you won't be aware of actually teaching people CPR, cardiopulmonary resuscitation, in the community. If somebody has a heart attack or drops down in front of you, what do you do? Vinnie Jones has led the more recent campaign of, getting in there, doing the cardiac compressions, doing the breathing, calling for early electricity, because early electricity in the form of defibrillation can potentially save a life. I believe that if we can get people more knowledgeable in first aid, then we can help the majority of injuries in the community setting.
Just wondered, with all the protocols and the systems in place in rugby, do you think rugby as a sport is in a good position to maybe not teach but aid other sports?
I think rugby is in a better position than it was several years ago. I think the realization that injury was perhaps becoming a little more prevalent, but was certainly becoming more serious, it was evolving and changing, was enough, and particularly the likes of the incident with myself, with Simon Webster. These kind of things have allowed us to have a much wider public debate in rugby than I think in many sports, because it's a contact sport and a lot of pathology occurs. And so we've evolved a reasonable system, and I say reasonable because you can always improve, and we're looking to improve. So the head injury assessment has gone from, if suspect, remove, to a 5-minute assessment, and now a 10-minute assessment. That is a much better situation, but I don't think that's the end of the game. Likewise with the rest of pitchside care for rugby. So we look at the way that we extricate people, the pitchside scenarios. We've changed the way that we use certain pieces of equipment. We've discarded some pieces, we've brought others in. I think other sports could learn from that. I'm not saying that we are the be-all and end-all, but because of the amount of pathology that we do see, we have learnt to adapt our methods, and so therefore we've made bespoke courses. other sports might learn from that. So standing at pitch side with my daughters at school when they were at school playing hockey allowed me to see a different injury pattern, and I started getting roped into helping the school evolve there. One of the things that I'm doing later in the day is to go and see the head of PE at a particular school because he perceives a problem that he'd like to share with me, and we'll see if we can adapt what they do to change that. So we're hoping to speak to drivers after this with Tony and you guys and see, share some experiences between driving, motorsport and rugby, see where the similarities are, where the differences are, and how we might evolve together, because you learn by speaking to people. One of the beauties of my job is that I get out, I've been lucky, I've got around the world literally at somebody else's expense, and you can speak to a lot of people. It's very humbling to go to these places and learn new things and sometimes impart some knowledge, and I would hope that that's what has happened today, and certainly I would hope that that's what happens after this seminar. Thank you.
I can just ask one last question before wrapping up. This is just pure out of curiosity, and doesn't need to be a long answer, but it was your point there about travelling all over the world and talking about rugby and seeing what different countries do. Got the IRB, other sports like cricket. I'm wondering if the sad incident the other week is a tipping point in cricket, whether some rule of legislation will follow a serious incident. And I presume on a number of occasions as an expert witness, you will be brought into various discussions. It would be useful to have an insight, or I would find it really interesting. Do different countries approach this problem differently, or is it pretty easy to get a consensus within the IRB?
No, I would say different people do approach things in different ways because they have different means and different perceptions of their needs. So, for instance, in Asia, where it is very much an amateur game, their priority was really to roll out initially first aid to the masses. So, therefore, the fair type course, first aid in rugby, I think was more important in countries like the so-called tier 1 countries, likes of Scotland, England, Australia, South Africa. The more bespoke so-called level 3 course, scrum caps, ISIS, that kind of course is more practical. So there are geographical and there are often cultural differences. Sometimes injury patterns are different. So, for instance, one country might have more head and neck injuries, another country might have more shoulder injuries. But we only learn this by actually speaking to each other. And one of the beauties of the International Rugby Board is that it has opened up a forum on an annual basis where lots of countries can come together and discuss matters and then evolve, ideally, global standards, but if not regional standards, if not country standards, and sometimes, it drills down to what's the need for a particular club. So I think that's a very good model that's been adopted.
Well, we're just over an hour. It's been a fascinating talk, and a series of discussions clearly contributed to the debate. I want to thank you all for being here in the second series within the seminar series, the Institute of Sport, Physical Education and Science here at the University of Edinburgh. Part of our job is to create debate, create discussion, keep us all informed, including the public, both public engagement, but also the creation and dissemination of knowledge through our own research. And it's always good to give the opportunity to talk about colleagues' research. So we have Dr. Christine Nash's new book just out over the last couple of days, the latest contribution from the Institute of Sport, Physical Education and Health Science to dissemination and creation of knowledge, Practical Sports Coaching, Dr. Christine Nash, published by Rugby the other day. Well done, Christine. But above that, can I just say thank you very much to Dr. James Robson for coming here to share his thoughts on head injuries and concussion in the sport. It's always great to have an insider's view, a really knowledgeable insider's view in terms of what's going on in the world of sports. So on behalf of the Institute, can I thank you very much, James, for sharing your thoughts.
Thank you. Thank you.